Hello students, good evening. So today basically we would be discussing the 2020 series that has been going on in DocTutorial. So I hope you all might have attended the exam that happened in ObGyn where there were 20 questions and I would be discussing that questions. Okay, so you are very close to your NEET exam. So this series is basically there because you stay in touch with the subject, you practice daily, and at the same time, the very next day itself, you get to discuss those questions directly with the faculty as well. So in between, if you have any questions or doubts, you can ask me in the chat box as well. So this will be a very brief, quick session because I know you're very close to the exam and you might be revising everything very rapidly. So we won't take up much of your time. So this will be a very concise discussion so that you can go through all the 20 important questions that came for yesterday's exam. So let's discuss the questions one by one. The first question was about morbidly adherent placenta. Which of the following type of morbidly adherent placenta is shown in the given image? So now, apart from this morbidly adherent placenta, the current terminology which is used is PAS. That came for the NEET. That 1 year back, this had come for the NEET. Instead of giving this morbidly adherent placenta, they just gave the short form, that is PAS. What is PAS? It is placenta accreta spectrum. So this spectrum basically includes placenta accreta, increta, and percreta. So they are asking you to identify what type of PAS is basically given here. So in this image, you can see that the placenta is encroaching into the level of serosa and slightly even going outside, which is basically your percreta. This is basically a case of placenta percreta that is shown in the image. So anything which is touching the serosa, which touches serosa or even goes beyond the serosa, is placenta percreta. So again, let me show you an image here. So the first image, you can see that it is just attaching to the level of the myometrium. It is just adherent to myometrium. So remember A and A, where it is adherent to myometrium. It is accreta, where it is invading into the myometrium. I and I, which is invading into myometrium, is increta, and finally percreta, which is touching the serosa. So again, this was previously asked. So remember that even if it is touching, just touching the serosa also, it is percreta. So which is involving serosa or even beyond. That is basically it is perforating the myometrium. So everything it is given in the first letter itself. A for A, accreta is adherent, increta is invading, and percreta is perforating. Special note, note that even when the serosa is just involved as well, it will come in percreta. So as the stage advances in percreta, this can extend beyond. It can extend anteriorly and involve the urinary bladder. It can go and invade into the blood vessels as well, which is the structure which is least likely to be involved. Least likely involvement is for the bowel involvement. Again, previous innocent question. So even blood vessels can be involved, the bladder can be involved, the serosa is involved. The least likely structure that is involved is basically the bowel. So this is your PAS or placenta accreta spectrum. Why does this happen? This is basically because the placenta separates from the uterus through a thin layer of fibrinoid degeneration. This is known as �𝗏𝑇 layer. There is �𝗏𝑇 layer which is present, which is a layer of fibrinoid degeneration which is present, which helps the placenta to separate from the uterus. In case of PAS, the �𝗏𝑇 layer is defective. The �𝗏𝑇 layer is defective, and it can also be due to defective decidualization. Which decidua is involved? It is decidua basalis. So you know, just below the placenta, you have this decidua basalis. The decidua basalis is basically involved in this condition. So there is defective �𝗏𝑇 layer and defective decidualization in this condition. So basically, when there is placenta accreta spectrum, so usually we suspect for a patient who has risk factors. So what are the important risk factors in which you will suspect this placenta accreta spectrum? The maximum risk is there when you have a patient with placenta previa associated with previous cesarean section. So the maximum risk is for placenta previa associated with cesarean section. As the number of cesarean sections increases, the risk of developing placenta eccrita spectra increases as well. So again, most important risk factor is previous cesarean section, which is associated with placenta previa. So what will you do for such a patient? If you have such a patient, such patients have to be delivered in a center of excellence where you have all the facilities. There should be facilities for an emergency cesarean section. There should be all multidisciplinary team which is involved, including the senior gynecologist, the urologist, because maybe the bladder is involved, intervention radiologists who can do procedures such as uterine artery embolization. There should be a specialist, there's an oncologist has to be there again for the detailed pelvic surgeries that might be involved along with it. There should be a good blood bank where blood and blood products can be availed at any time. So where will she deliver? In a center of excellence. And usually we plan the delivery between 34 to 36 weeks. 34 to 36 weeks. How will you deliver the patient? Can you go for a vaginal delivery? No, again here the method of delivery is going to be a cesarean section. So we usually give a classical scar. So we usually give a vertical scar initially in the abdomen as well, so as to deliver. Then we give a classical scar, that is a vertical scar, so as to not involve or go into the level of this placenta which is invading. We take out the baby, deliver out the baby, then we will proceed with hysterectomy. So what do we usually do? There is cesarean section followed by hysterectomy. If I try to pull out the placenta, take out the placenta, there will be torrential bleeding that is happening. So we usually first deliver the baby by giving an upper vertical incision. Then after the delivery of the baby is completed, we go or proceed with a hysterectomy. Usually we give the incision in such a way so as to avoid incising the placenta. So we do a planned cesarean section where we give an incision so as to avoid cutting over the placenta. After this, the delivery of the baby has been completed, we go ahead with hysterectomy. So this is a very important topic. Placenta eccrita spectrum, there's a lot of articles, questions coming on this topic. Okay, so very important. There has been frequent questions from this topic as well. So this is about your placenta eccrita spectrum. This is a cross-sectional view which is showing the same thing. So again, what do you see? In eccrita, it is basically adherent to the myometrium. In creta, so this is the myometrium. In creta is invading into the myometrium. And where is serosa involved? Once the serosa involved or even beyond the serosa, that is perforating through the uterus, your answer is per creta. It is per creta. Any questions or doubts? Okay, so let's go ahead with the next question. So this is a direct question. What is the embryological origin of lower part of vagina? So this is basically from the anatomy and embryology part. So these are the various structures and from where does they develop in the genital tract. So ovary basically develops from the genital ridge. Genital ridge. The fallopian tube, uterus, cervix, and the upper part of vagina develops from the Mullerian duct. So these are from the Mullerian duct. Among this, the fallopian tube is basically from the unfused part of Mullerian duct, whereas your uterus, cervix, and upper part of vagina is from the fused part of Mullerian duct. The lower part of vagina, which is given in the question as well, the lower part of vagina basically arises from the urogenital sinus. As you see, the vagina has dual development. That is, it has some contribution from the Mullerian duct and some contribution from the urogenital sinus. But vaginal lining is derived from just one part, and that part is urogenital sinus. So vaginal lining is basically arising from the urogenital sinus, and it is basically from the endodermal cells. Endodermal cells of urogenital sinus. Okay. So moving ahead with the next question, what is the ideal number of antenatal visits during pregnancy? Can you answer? What's the ideal number of visits during pregnancy? Is it 4, 8, 12 to 15? The ideal number is actually 12 to 15. So we basically ask the patient to come in every trimester till she is 28 weeks. Then we call her every 2 weekly. So after every 2 weeks, she'll be coming to us till 36 weeks. And after 36 weeks, we call the patient weekly. So how is the antenatal visits planned? Till 28 weeks, it is going to be 4 weekly, that is monthly visits. From 28 till 36 weeks, she will come every 2 weeks, that is 2 weekly visits. And beyond 36 weeks, she would be having weekly visits, which accounts to up to 12 to 15 visits. It's the ideal number. So please be very careful when you read this ideal visits, 12 to 15. If they ask you minimum number of visits, so minimum number of visits as per WHO, minimum visits as per the WHO is 8. It's not 4. No, it's not 4. It is 8. 4 is the older one, which is given by the focus model. So as per the WHO, it is 8. And as per Government of India, it is 4 visits. So the minimum number of visits as per WHO is basically 8. Again, previously asked question. Coming to the next question. So this is basically about the obstetric score. You have a 32-year-old female who has come to the OPD. She is 10 weeks gestation. She has a 5-year-old child who was born at 34 weeks. And again, there are 2 first trimester abortions as well. What is the obstetric score? So let's briefly see what an obstetric score is. So again, it is basically represented in the format of GPLA. G stands for gravida. Gravida includes all the pregnancies. Her present as well as past pregnancy will be included in gravida, regardless of the outcome. Let it be abortion, preterm, term, whatever. All pregnancies are included in gravida status. So here, how many pregnancies are there? A present pregnancy, 2 abortion, and 1 pregnancy at 34 weeks. G4. The next one is parity. So parity means all past pregnancies that has crossed viability. So please note, parity only includes past pregnancies, not her current pregnancy. So she had only 1 pregnancy previously which has crossed the viability, that the baby was born at 34 weeks. So what is P? P is 1. Again, that baby was living, so living issue is 1, and she has 2 abortions. So her obstetric score is G4, P1, L1, and A2. So let's look for the option. G4, P1, L1, and A2 is her obstetric score. Yes. Yes. Coming to the next question. Which of the following is part of the WHO guidelines for management of second stage of labor? So during the second stage of labor, when the head of the baby is delivering, there is a risk for a perineal tear to happen. So as there is this risk, do we routinely give an episiotomy? So many times, even in the labor room, you might have noticed that many times episiotomy is given right and left for so many patients. But you have to understand that ideally, episiotomy is not a routine. Routine episiotomy is not indicated. We give an episiotomy whenever there is an indication, such as when I suspect a tear, such as there is a macroscopic baby, where we are applying any operative vaginal delivery, such as I'm using a forceps, a vacuum delivery, where I have to do some internal maneuvers, such as in shoulder dystocia. These are few indications where I have to give episiotomy. Routine episiotomy is not indicated actually. So again, the first statement is wrong. So what should I do to actually decrease the chances of perineal tear from happening? We should give a good support to the perineum. So we apply a hand just below the head so as to give a perineal support. We flex the head of the baby so as to get a controlled extension of it. So you have to give manual support to perineum and maintain flexion of the head. So that is correct. Never give warm compress to the perineum. No, ideally warm compression, that is applying some warm compression on the perineum, has actually shown to decrease the risk of perineal tear. So again, warm compression can be given. You have to perform labor in lithotomy. So many times you might have seen the patient being kept like this in the lithotomy. Again, lithotomy is not a routine. It is now told that the patient can deliver in any position of her choice. She can deliver in standing position, sitting position, even in lithotomy position. So position of her choice. Again, lithotomy is not a routine. So understand that episiotomy is not a routine. Lithotomy is not a routine. Warm compression can be given. This is given, never given. So again, that is from what is correct? Manual support to perineum to maintain flexion of the head. Yes. Coming to the next question. You have a 37-week primary gravida who has come to you with mild labor pain, which is persisting for 20 hours. And it is seen that she is 1 centimeter dilated and uneffaced. How will you manage this patient? Okay, so this is a very commonly asked question, commonly tested concept, and you should be thorough about it. What are they asking you in this question? Can you give me the answers in the comment if possible? Okay, now I'm seeing the comments actually. Till now I was seeing no comments. Okay, now we can see. So what is this phase? Yes, user has basically asked, latent phase is more than 20 hours and prolonged latent phase. Why not induction? Okay. So what is the importance of this latent phase and active phase? So in latent phase, the patient can take more time to deliver. The active phase concept itself has been introduced so that we are very active in the active phase where we do all the interventions such as artificial rupture of membrane, giving her oxytocin, all these things are done. In latent phase, we should not do unnecessary interventions. In latent phase, if the patient is there, initially you are going to give sedation and monitor the patient. You will give the patient. Usually what happens is that after sedation, she goes to sleep and usually she wakes back in active labor. So in latent phase, you don't directly forgo for interventions such as augmentation, cesarean, amniotomy. This is a repeatedly tested concept. So you have latent phase, you have active phase. So in latent phase, do not choose any intervention. Initially, you are going to give sedation and continue to monitor the patient. In active phase, once the patient is in active phase and you see that the rate of progress is less, usually the minimum rate of progress is taken as 1 centimeter per hour. You see that the rate of progress is less in active phase, then you can do this oxytocin. And the other option is artificial rupture of membrane. Again, I have discussed in detail when to do ARM first, when to give oxytocin first. So usually just briefing about that as well. Ideally, what we do initially is artificial rupture of membrane. Then again, we reassess the patient. If still the rate of progress is less, then we go for oxytocin. But in conditions where the head is high, when the head is high or when we suspect that the cord can come out easily, in those situations, you will give oxytocin first, bring down the head of the baby, then go for an artificial rupture of membrane. Again, please note that, again, a very common scenario, patient is in active phase and they give you some findings such as there is caput, there is molding. What does they suggest? There is a lot of caput, there is 2 plus caput, there is 3 plus molding. All these are suggestive that there is some form of cephalopelvic disproportion. So there is some form of CPD, the patient is going to obstructed labor. In those scenarios, you are going to choose for cesarean section. So question gives you findings suggestive of obstructed labor. Let that be in active phase also. Once there is symptoms of obstruction, still you won't give the additional power such as by giving oxytocin or ARM, then you are going to choose the cesarean section. What is ARM? ARM is artificial rupture of membrane, which is equivalent to your amniotomy. Your correct answer is your sedation and rest. So what is the cutoff between this latent and active phase? So previously, as per the WHO, which is basically the modified WHO. The commonly seen partogram is basically your modified WHO, which is the older one. There the cutoff was 4 centimeter. But if they ask you WHO now, just WHO, which is the current WHO, the cutoff is 5 centimeter. And as per ACOG, it is 6 centimeter. The current WHO, the latest partogram that is given is the next generation partogram, which is given in the labor care guide. So if they ask you, rephrase the question, ask you labor care guide, again the cutoff is 5 centimeters. So the latest WHO is 5 centimeters. Yes. Okay, very good. So I can see that everyone is answering very well in the comment section as well. Very good, correct. So obstructed labor, CPD is there, then you're good to give the patient, do the cesarean for the patient. Will oxytocin be effective as cervix is not right? Not in this scenario, dear. So yes, user has asked, will oxytocin be effective in this scenario? Not in latent phase. In latent phase, if we start this oxytocin and all these intervention early, very likely she will not progress and she will end up in cesarean section. But in active phase, once the active phase has reached, the cervix is more right? That means she is basically beyond 5 centimeters. Okay, so in those situations, yes, we can give oxytocin so as to hasten the labor. Yes, current is 5 centimeters. Very good, Pratyusha. Yes. Okay, Gajendra has told that. So it was a UPSC question. Yes. So these are all the updates, right? So it's very likely to be asked this later. What are the stages and those question about placenta accreta spectrum? Very frequently we see those in the question papers as well. So can you identify the device which is shown here? Is it a Lippes loop, misoprostol insert, Mirena? This is basically the cervidal vaginal insert. Yes. So I had given you various pharmacological methods of induction of labor. So the methods of induction include, you have this misoprostol, which is basically PGE1 tablets. Then you have this dinoproston. What is dinoproston? It's right there in the name itself. Dinoproston is PGE2. And what is PGF2 alpha? That is carboprost. You can't see that here because carboprost is a drug that is used for PPH. It's not for induction, it's for PPH. Okay, PGF2 alpha, carboprost. So misoprostol, that is PGE1, we usually give it as tablets at the dose of 25 microgram, not milligram. It is 25 microgram. 25 microgram tablets can be given either as orally or vaginally. Usually we prefer the vaginal route, and we repeat the doses 4 to 6 hourly for maximum of 6 doses. This is from the latest William 26 edition. So again, the next is your dinoproston. It is basically a gel. So where do you insert it? It is intracervical installation. Please note it's not intravaginal, it is intracervical. The dosing is 0.5 milligram. We usually repeat it 6 hourly, maximum 3 doses. Again, important, 6 hourly, maximum 3 doses. The third one that you see here, this is again dinoproston, but this dinoproston is present as a vaginal insert. So we basically insert this at the level of posterior fornix. At the level of posterior fornix, we keep this vaginal insert, which is known as cervidal vaginal insert, which basically again has your PGE2, that is dinoproston. What was the dose that I gave in the gel? It is just 0.5 milligram. What is the dose that is given in this insert? It is 10 milligram. So again, the other differences include this dinoproston gel. We had to repeat it 6 hourly, whereas I'm going to keep this insert for a period of 12 hours. It will release, there will be a slow release of PGE2 from the posterior fornix. If at all the patient gets contraction or the 12 hours have passed, we can just remove this cervical insert, that is cervidal. Okay. Intracervical dinoproston, exactly correct. Very good. Yes. Coming to the next question on twin pregnancy, you have a primigravida who has come with complaints of severe nausea at 12 weeks. On examination, you find that the fundal height is more than period of gestation. Fundal height more than period of gestation, severe nausea, which is basically due to the increased level of beta HCG, are slight pointers towards twin pregnancy. Apart from this, ultrasound shows that there is 𝗕 What is the most likely diagnosis? They're asking you about the type of twins that is there. So T sign and lambda sign are the two important signs that you get in twin pregnancy. You get at to lambda sign. This is your lambda sign. This is seen in case of DADC twins, diamniotic dichorionic, also known as dichorionic diamniotic twins. The next one that you see, this is your T sign. This is your T sign, which is seen in case of monochorionic diamniotic twins. Monochorionic diamniotic twins. So where do you see this T sign? It is seen in monochorionic diamniotic. So this lambda sign can also be written as this twin peak sign. So twin peak sign is nothing but again this lambda sign. When do you assess for this chorionicity? The assessment of chorionicity is usually done between 11 to 14 weeks. Why do I assess for chorionicity? What is the importance so as to diagnose this early? This chorionicity is basically important because the prognosis depends on chorionicity. What happens in case of monochorionic twins where they basically share a placenta, the risk of complications are more. They have complications such as TTTS, twin transfusion syndrome, TAPS, twin anemia polycythemia sequence, and TRAP, twin reverse arterial perfusion. These complications are specific to monochorionic twins. So T sign and twin peak sign or the lambda sign, which is seen in case of diamniotic dichorionic. Let me write it so that there is no confusion. You have the lambda sign here and the T sign. Lambda sign is also known as twin peak sign. What are the other things that you will see? When you measure the number, the thickness of this inter-twin membrane, you see that the thickness of the inter-twin membrane is more than 2 millimeter here, whereas it is less than 2 millimeter in case of monochorionic diamniotic twins. The next difference is that if you count the number of layers, in case of diamniotic dichorionic, you can see 4 layers. There are 4 layers, whereas in case of monochorionic diamniotic, there are 2 layers. There are 2 layers. You can see here 1 layer and the second layer. How come there are 4 layers here? I mean, sometimes students ask this question. So let me just draw that for you here. So one amniotic membrane. From one placenta, there will be some placental tissue that is ebetic. From the next placenta, also some tissue that is ebetic. And the fourth amniotic layer. So how many layers? 1, 2, 3, 4. There are a total of 4 layers that is seen. Okay. Next, a patient at 34 weeks of gestation presented with placenta previa. Which of the following statement about this condition is false? So they're asking about placenta previa. So what are the typical features that you see in case of placenta previa? In placenta previa, usually there are a lot of P's, right? So many P's. What are those P's? Usually you have painless bleeding. Usually the bleeding is profuse. Usually the symptoms are out of proportion to the bleeding that she is having. The signs and symptoms that she has is out of proportion. That is again another P which is involved in this. And usually, so the first thing that I write is the P's. You have painless bleeding. It is profuse. It is fresh in color. It is fresh blood that is coming out. And symptoms are proportionate. It is proportionate. The symptoms are proportionate to the bleeding. So the first point, that is painful bleeding. Is it right? That's wrong. Next is uterus is relaxed in this. Yes. In case of your placenta previa, the uterus is relaxed in contrast to your abruptio placentae, which also presents with antepartum hemorrhage. In abruptio placentae, you see that the uterus is contracting. The tone of the uterus is increased, whereas uterus is relaxed in case of placenta previa. The next is you see a floating head can be palpated. Is it floating? Yes, as the placenta is low. As the placenta is low at the level, again, there are different types of placenta previa. You have the older Brownies classification and the newer classification. So depending on that, not going to the types or grades of placenta previa. So once this placenta is low down, covering over the internal os or even completely covering or just reaching near the internal os, whatever that is, again, the fetal head can't come down completely. It is obstructed by this placenta. So you feel that the head is floating. It is above and it can be floating head. The size of the uterus usually correspond to the gestational age. In contrast to abruption, again in abruption you see that the size of the uterus is more than the period of gestation. So the wrong statement is painful bleeding. Okay. So again, it's very important to differentiate between placenta previa and abruptio placentae. So let me just tell you briefly the points about abruption as well. Abruption, you see that the patient has painful bleeding. Usually there is some preceding factors for the patient, such as there could be history of hypertension, trauma, all these preceding risk factors could be there for the patient. Once you examine, you can't feel the fetal part properly because the tone of the uterus is increased. As the bleeding can be collected within the uterus, you might feel that the size of the uterus is more than the period of gestation. How will you diagnose placenta previa? What is the investigation of choice in placenta previa? The investigation of choice in placenta previa is TVS, more than TAS. So students, please note that we will never do a per-vaginal examination in placenta previa. PV is absolutely contraindicated because if I poke the placenta, there can be massive bleeding that is happening. So I will never do a PV. But can I do a TVS? Absolutely yes. TVS can be done in placenta previa because I won't poke till the placenta with the probe of the TVS. We can stop short of the cervix. So again, TVS is the investigation of choice and not TAS. Okay, so if you have to choose between this, TVS is preferred over TAS. What is the management that we give in case of placenta previa? It is a conservative management, also known as expectant management, which is given by McCuffey and Johnson. So this is known as McCuffey and Johnson's regimen is followed in this. When you deliver the patient, what is the method of delivery? The mode of delivery in case of placenta previa is cesarean section. The mode of delivery is cesarean section. Again, baby can't come out through this placenta which is already obstructing the os, right? So you just give a cesarean section and deliver out the baby. So method of delivery is cesarean section. Yes, correct. Kalimikonda, yes, you have told it correct. McAfee and Johnson's regimen, conservative management, very good. Yes, okay. So the next question is, the pregnant woman presented with blood-tinged vaginal discharge at 35 weeks. So the patient has vaginal discharge and nitrosin paper test was performed. What is the purpose of this test? So when patient presents with this vaginal discharge where we suspect that she could have ruptured the membrane, where she might have had a PPROM, premature rupture, preterm premature rupture of membranes, the test that we do is nitrosin paper test. So what is the basis of this test? So the basic principle is that the vaginal secretion, as you know, is acidic. Vaginal secretion is acidic and the amniotic fluid is more alkaline. So what will happen? So basically, whenever such discharges come, we have some differential in our mind. One is maybe she is leaking the urine which is coming out, or it could be excessive vaginal discharge that is coming out. Next is maybe it is the frank amniotic fluid that is coming out after a rupture of membrane. So this nitrosin test will tell you whether it is amniotic fluid. If it is amniotic fluid is alkaline, and the nitrosin paper test will turn blue. If it is vaginal secretions, it is acidic, and the nitrosin paper will turn red. What about the other test? So the test that helps to detect this Rh isoimmunization. What's the test that we do to detect fetal blood cells in Rh isoimmunization? Can you please summarize? Oh, yes, we are going into that, dear. We are summarizing all tests as well. Yes. So what is the test that we do in Rh isoimmunization? That test is Glihoyer-Bethke test. So this is the test that we do for detecting fetal RBCs in Rh isoimmunization, Glihoyer-Bethke test. So again, in this test, basically you are adding an alkaline medium to it. So with which you will understand that the fetal RBCs, which are resistant to any form of denaturation, will retain its color. So the important point that you have to know is Glihoyer-Bethke test is used in Rh negative pregnancy. to detect for RH immunization. It is a quantitative test. Quantitative test. That means it will tell me how much feto-maternal hemorrhage has happened. It will tell me how much feto-maternal hemorrhage has happened, with which I can calculate the dose of anti-D that has to be given to the patient. Anti-D that has to be given to the patient. This is your 𝗗liche𝗵𝗋𝗃 test. So again, this is basically testing for the fetal RBC. This is testing the fetal RBC in mother's circulation. The main principle of this test is that fetal RBCs are resistant. Fetal RBC is resistant to denaturation. Resistant to your denaturation. So you might have heard a very similar test, which is given in the next option. What is the test that is used in 𝗂𝘂 𝗃𝗍? Again, I want to differentiate. This 𝗂𝘂 𝗃𝗍 basically means there is these fetal blood vessels. There are these fetal blood vessels which are transversing over the level of your internal os. So just above the os, you have the fetal blood vessels which is breaking, which is leading to the fetal blood that is coming out. So again, I'm doubtful. Is it the baby's blood? Is it the mother's blood? So this test will help me to differentiate for the fetal hemoglobin in 𝗂𝘂 𝗃𝗍. It is your AB test. Okay, it is your AB test, which is known as 𝗵𝗃 denaturation test. So you have your AB test for 𝗂𝘂 𝗃𝗍. 𝗂𝘂 𝗃𝗍, you have AB test, which is also known as 𝗵𝗃 denaturation test. Okay, so this basically uses an alkali as the medium. So you are using an alkali. Again, this alkali will denaturate the mother's RBCs, but not the fetal RBCs. Okay, in 𝗗liche𝗵𝗋𝗃 test, you are not using an alkali. It's actually an acid that you are using. You are using acid citrate. You are using an acid, which is acid citrate. This is also known as acid elution test. Acid elution test. Elude, something eluding means something goes out. So what will happen once you add this acid? All the maternal RBC will lose its color and it will appear like ghost-like cells. Okay, whatever points are given here, that will be enough about these tests. Okay, so yes, someone has told that yes, RH is very important topic. Yes, we want to know briefly about RH. I guess yes, right? Again, so many questions on RH very commonly asked as well. So someone has commented about ICT as well. So let's briefly see what it is. Okay, so in RH negative pregnancy, so when do we do this ICT? If a patient comes to you who is RH negative, patient has come to you, she is RH negative, first thing that you are going to do is husband blood group. Many a times I see the students struggling with the topic of RH as well. So let's take this opportunity briefly to discuss about RH. Okay, so RH negative pregnancy, you check for the husband blood group. If the husband blood group is positive, there is a chance that the baby could be positive and there is risk of immunization. So if the husband blood group is positive, the next thing that I'm going to do is ICT. What is ICT? Indirect womb test. Where is it done? It is done in the maternal blood. In the mother's blood, I'm going to do this ICT, indirect womb testing. So after doing the ICT, if the ICT is continuously negative, if the ICT is negative, so usually I'm going to repeat it 4 weekly. We'll do 4 weekly ICT. It's continuously negative at 28 weeks. Also ICT is negative. I'll give her anti-D. This anti-D is known as routine antenatal anti-D prophylaxis. So remember, antenatal prophylaxis with anti-D. So I'm going to give the prophylaxis of anti-D at the period of 28 weeks. Then again, we'll follow up the patient after the delivery. So once the delivery has happened, I will check the baby's blood group. I will check the baby's blood group. If the baby's blood group is negative, should I give any anti-D? No need. If the baby's blood group is positive, if the baby's blood group is positive, the next thing that I'll see is what is the DCT. If baby's blood group is positive and DCT is negative, in that situation, we will give anti-D. I have discussed this algorithm in our regular classes as well, also in the app as well, and the same question has come for the latest NEET exam as well. So when will you give the anti-D? Baby blood group is positive and DCT is negative. In that situation, you will give anti-D. If the DCT is positive, already the immunization has happened. There is no role of giving anti-D. Very important, the statement you have to remember, baby blood group is positive, DCT negative, you again give anti-D. So what is the dose of anti-D that you give? As Gajendra has rightly pointed out, the dose of anti-D that you give is 300 microgram. 300 microgram, it is given as intramuscular injection. The same dose is given at this 28 weeks as well as after delivery. 300 microgram, that is intramuscular injection. If you have a pregnancy which is at a lower period of gestation, less than 12 weeks, the dose of anti-D that you give is 50 microgram. It is 50 microgram. Okay, so this is about your RH negative pregnancy. If ICT is completely negative. If you see that RH negative, ICT is positive in between. If ICT is positive, then the next thing that you're going to do for her, you'll basically look at the titer. You will look for ICT titer. And you have something known as critical titer. Critical titer is that value above which the risk of all this anemia developing in the baby is very much higher. So what is this critical titer? The critical titer is 1:16. If the critical titer is more than or equal to 1:16, what is the next thing that you will do? You will monitor the patient with MCAPSV, middle cerebral artery peak systolic velocity. Middle cerebral artery peak systolic velocity. MCAPSV, if it is more than 1.5, so you can just remember 1.5, but the ideal answer is 1.5 MOM, multiples of median. So basically we do the scan, we get this value. Once you see that middle cerebral artery, this flow or the velocity is increased, it is suggestive of fetal anemia. Fetal anemia. Okay, so as it's a revision class, I'm going a bit fast. Is the speed okay? You want me to explain anything again or slow down or even speed up? You can just comment in the chat box as well. Okay, so even if I go very slow also, okay, it might be difficult now. So that's why I'm not going that slow. Okay, just tell me if the speed is okay. All right. Okay, so moving to the next question. So in evacuation of the patient with secondary amenorrhea, you administered estrogen and progesterone, but the withdrawal bleeding does not occur. So what's the likely location of lesion in this case? What is, okay, speed is okay. Thank you, Shota doctor. Okay, thank you for that input. Okay. So this is basically a question about secondary amenorrhea. So the next 10 questions will be on gynecology. The initial 10 were on obstetrics. So next will be on gynecology. Yes. So in secondary amenorrhea evaluation, the first thing that you do for all patients, the first thing that you have to check is urine pregnancy test. Why? The most common cause of secondary amenorrhea is pregnancy. You will do urine pregnancy test. What do you do next? The next thing that we do even clinically in clinical practice as well is give the patient progesterone. We will give progesterone to the patient. Usually we give some drugs such as Meprate. We give it twice daily for a period of 5 to 7 days. 5 to 7 days this progesterone is given and we suddenly stop this drug. That is, we withdraw progesterone. This is known as progesterone withdrawal test. Progesterone withdrawal test. If after giving this progesterone and stopping it, that is progesterone withdrawal test, still there is no bleeding. If you see that still there is no bleeding, the next thing that you're going to give is you will supplement estrogen as well as progesterone. You will give estrogen and progesterone to the patient for a period of nearly 21 days, then stop these medicines. If at all the problem is at the level of hypothalamus, pituitary, ovary, Basically, you have given her hormones. Whatever was the function of hypothalamus, pituitary, ovary, you have taken care of that, right? So if at all the problem was at the level of hypothalamus, pituitary, ovary, she should bleed with that. So she will have bleeding if the problem is at the level of hypothalamus, pituitary, or even ovaries. If she does not still have bleeding, there is no bleeding even after giving estrogen and progesterone, that means problem is at the last level, that is at the level of uterus, or even could be at the level of vagina, that is outflow tract obstructions as well. So among these options, uterus is given. So if the problem is at the level of uterus, or they can give you problem at the level of endometrium. They can slightly rephrase the question and give it as endometrium as well. Problem at the level of uterus, endometrium, in all this situation, you won't find any bleeding after giving estrogen and progesterone. So the problem is at the level of uterus. What is one acquired cause where you have no bleeding as a secondary amenorrhea case after history of D and C, where the problem is at the level of endometrium? Yes, it is 𝗵𝗂𝗯𝗀 syndrome. Okay, so instead of giving uterus endometrium, they can give a differential even as 𝗵𝗂𝗯𝗀 syndrome. Usually, typically in history, they will give you some pointers, such as there will be history of D and C's in the patient. So again, for the same patient, if the problem is at the level of endometrium or uterus, if I do the FSH, LH levels, what will be the problem? What will be the level of FSH, LH, or even estrogen in this woman? In this, the level of FSH, estrogen will be normal. If the problem was at the level of ovary, what will be it? You will see that the FSH levels are increased and estrogen level is decreased. If the problem is at the level of pituitary or hypothalamus, you see that the FSH level is decreased and estrogen level is decreased as well. Okay, so again, my YouTube channel as well, I have given a 10-minute summary of all the amenorrhea cases, how to deal with it. You can go that in detail. I'm not going into that in detail, but this secondary amenorrhea algorithm, you have to initially UPT, then progesterone withdrawal, then estrogen plus progesterone withdrawal, and finally, if there is no bleeding still with that problem, you will suspect at the level of uterus. Coming to the next question, patient presents with complaint of urine dribbling from the vagina during micturition. She has a history of obstructed labor. You perform a methylene blue 3 swab test and the lower swab gets stained. What is the likely diagnosis? If this final part was not there, I would have first thought about a VVF, vesico-vaginal fistula, which is C, the most common type of fistula after the most common cause of vesico-vaginal fistula after an obstructed labor. It's actually after an obstructed labor. Most common cause of vesico-vaginal fistula is actually obstructed labor in case of your developing countries. That means like India. So if they just ask you most common cause of VVF, it is basically obstructed labor. In case of your developed countries, the most common cause is surgeries, such as hysterectomy is the most common cause of VVF. Here they have given an additional information, lower swab only gets stained. So let's see what is this 3 swab test. So in this test, I'm basically going to insert 3 swabs inside the vagina. And we will fill the bladder with a dye, that is your methylene blue dye. So I have filled the bladder with this blue dye. What will happen is that there could be 3 types of fistula commonly. It could be a vesico-vaginal fistula, fistula between the bladder and the vagina, vesico-vaginal. It could be a urethro-vaginal fistula between the ureter and vagina, or urethro-vaginal fistula between the urethra and vagina. If the fistula is urethro-vaginal, so connection between the ureter and vagina, you see that the dye does not go into the ureter. So you will see that this swab is basically stained, is basically soaked but not stained. You will see that the swab is soaked with the dye, but there is no stain. As the dye does not go to the ureter, again there is no stain. If it is urethro-vaginal fistula, again this dye will come through here and it will stain the lower swab. So by now you might have got the answer. Urethro-vaginal, you will see that the lower swab is soaked as well as stained. In vesico-vaginal fistula, it's usually the middle swab which is soaked and stained. So let's quickly write that. Ureterovaginal, you will see that the upper swab is soaked but not stained. Not stained. In case of your vesico-vaginal fistula, you see it is the middle swab which is soaked and stained, and ureterovaginal, it is basically the lower swab which is soaked and stained. Yes, ureterovaginal fistula. Which symptom is most commonly associated with endometriosis? Endometriosis is the most common symptom. It's the pain she has. And among the pain, the most common is dysmenorrhea. She has all types of pain, including dysmenorrhea, dyspareunia, chronic pelvic pain. The patient, the dysmenorrhea can be progressive. Patient have progressive dysmenorrhea. They have something known as triple dysmenorrhea, that is pain before periods, during the periods, and even after the menstruation. So they have triple dysmenorrhea. Pain is the most common symptom. And among pain, the most common is dysmenorrhea. Apart from this, the other symptoms include the patient can have infertility, the patient can have head neck cell mass. The patient can have infertility and head neck cell mass are the other symptoms. So usually the triad is pain, infertility, and head neck cell mass. Why does this head neck cell mass happen? This is basically due to your endometrioma, which is your chocolate cyst. This is due to endometrioma. Endometrioma. So you have a patient who has this pain, infertility, head neck cell mass. What is the next investigation that you're going to do for the patient? The next investigation that you will do is, it's an ultrasound. It is ultrasound. And usually we prefer the TVS. TVS is the ultrasound that is done initially. So again, ultrasound might not give you much information. What can ultrasound show? They can show you an endometrioma. They can show you this endometrioma or this chocolate cyst, which basically has a ground glass appearance. Ground glass appearance on ultrasound. So I told that what is the initial investigation, or if they ask you what is the next investigation that you will do, your answer is ultrasound. But if they specifically ask you what is the investigation of choice, I can't see the small deposits in the peritoneum over the various parts which is there with an ultrasound, but I can see it directly. So what will I do? I will insert a scope, that is your laparoscopy. Your investigation of choice is laparoscopy. But if they ask you the gold standard or the confirmatory investigation, gold standard investigation, confirmatory investigation is laparoscopy along with histopathological examination. That means you take a biopsy and examine. So if you have to choose between laparoscopy and histopathology, your answer is going to be histopathological examination. All these points are important. What is the next investigation? What is the investigation of choice? What is the confirmatory investigation of the gold standard investigation? That is histopathological examination. Okay. Yes. On to the next question. A woman comes to the OPD concerned about excessive growth of coarse hair over the face and chest. What is the scoring system that is used to clinically grade this condition? So what is this excessive hair growth over the face, chest? This is your hirsutism. In hirsutism, the test that you do is your Ferriman-Galloway scoring. Ferriman-Galloway scoring. What about the other scorings that is given? So Ludwig score, again, that comes in dermatology, that is basically to assess for the hair loss. Amsel score and Amsel's criteria, again, that's coming up in the coming up slides. Actually, Amsel's scoring is basically used in case of your bacterial vaginosis. You have Prader scoring. Prader score is used in case of virilization. So if a patient has virilization, you give this Prader scoring. Ferriman-Galloway is for hirsutism. Amsel is for bacterial vaginosis. For hair loss and the balding assessment, you can use this Ludwig score. Okay, again, just a point about this Ferriman-Galloway scoring. Once you see that the Ferriman-Galloway score is more than 8, score more than 8 is suggestive of hirsutism. All right. Yes, this was I told you that I will be discussing the Amsel score or Amsel's criteria as well. Okay, so a young woman has presented to you with bacterial vaginosis. Which of the following statements is incorrect about her condition? So in bacterial vaginosis, you see that usually the causative organism is multifactorial. There can be multiple organisms, but a commonly implicated one is Gardnerella vaginalis is a causative organism which is associated. We usually use a criteria here, which is known as Amsel's criteria. With Amsel's criteria, we would be seeing the various other features of bacterial vaginosis as well. So here I have given the Amsel's criteria. You see that there is a thin gray homogeneous discharge. So there is profuse homogeneous discharge, which is usually thin gray in color. The next is that you get a test, which is your amine order when you add your KOH, which is known as WIF test. So in WIF test, you get an ammoniacal smell, a fishy odor when you add your KOH, that is potassium hydroxide, to the secretions. Next is there is presence of clue cells in microscopy. What are clue cells? Again, important. Clue cells are basically the vaginal epithelial cells. You get these vaginal epithelial cells which are studded with this bacteria. So you get cells like this with dot, 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 dot. This is basically your clue cells. These are the vaginal epithelial cells which are studded with this bacteria. Finally, you see that the vaginal pH is more than 4.5. So vaginal infections such as your trichomonas infection, bacterial vaginosis, all this make the vaginal pH alkaline. It becomes more than 4.5. Whereas in case of your candidal infection, you see that the vaginal pH is acidic. The pH is less than 4.5 in case of candidal infection. Here it is more than 4.5. Final statement, metronidazole is given for treatment. Yes, metronidazole is the treatment of choice in bacterial vaginosis. Again, metronidazole is again the treatment of choice in trichomonas infection as well. What is the difference? Bacterial vaginosis, you don't require a partner treatment. Trichomonas, partner treatment has to be provided. Very important. Where will you give this partner treatment? In trichomonas infection, you have to give this partner treatment. What about vaginal itching? Vaginal itching is absent in case of your bacterial vaginosis. Vaginal itching can be seen in case of trichomonas as well as candida infection, which are again vaginal infections, but vaginal itching is not present here, which is the correct answer. So again, Amsel criteria is very important. You have to know this criteria. And among these 4 criteria, which I told, if a woman has 3 out of these 4 criteria, I will diagnose it as bacterial vaginosis. Okay, so differentiating the various vaginal infection, bacterial vaginosis, identifying clue cells, and knowing the Amsel's criteria, all these are important. So as we have touched upon the management, let me just finish with the management of this candida as well. In candida infection, the management is fluconazole. The treatment is fluconazole. In trichomonas, some key points that you get is you have this strawberry cervix, which is there, which is basically, you can see the red spots which are there over the cervix, the strawberry cervix. You get the green frothy discharge, which is there. Okay, so these are some of the important points about trichomonas as well. Coming to the next question, which of the following is not a risk factor for pelvic inflammatory disease? So pelvic inflammatory risk increases if the patient has multiple history of unprotected intercourse, early age of first sexual intercourse, multiple sexual partners. If the patient uses some intrauterine devices, again the risk is slightly more. So among IUD users, the infection that is associated is actinomyces infection. You get actinomyces infection, which is associated with IUD users. Whenever the risk of these sexually transmitted infections decreases or the spread of this organism decreases, the risk of PID also decreases. So once the patient is using a barrier method of contraception, the risk is not increased as such. Which of the following is not a risk factor? Barrier method of contraception is not a risk factor for pelvic inflammatory disease. So PID, again, the causative organism can be many. It could be due to chlamydia, gonorrhea, tuberculosis. Previously, TB was the most common cause. Nowadays, chlamydia is coming up, even about TB as well. So now chlamydia is the most commonly implicated organism that you see with PID. So anything that increases sexual intercourse, If there's unprotected sexual intercourse, multiple sexual partners, early age of first sexual intercourse, all these increases the risk. Even IUDs has been associated. IUDs are more associated with actinomyces infection. All right. Going to the next question, what is the minimum endometrial thickness? At what minimum endometrial thickness are you going to perform an endometrial biopsy in a patient of postmenopausal bleeding? Very important. If a patient presents to you with postmenopausal bleeding, and in the ultrasound, you see that the endometrial thickness is more than or equal to 4 millimeter. That is when you will go for endometrial biopsy. Initially, we do biopsy with a very thin refill-like instrument. What is this? This is basically your pipelle. This is your pipelle. Yes, this is your pipelle, which you take endometrial biopsy. The advantage of pipelle is it's very thin, so the pain is less. The patient does not require any anesthesia. It is an OPD procedure, so there is no requirement of any admission as well. So initially we attempt biopsy with this Pipelle's cannula. The other methods of biopsy include, you can use a Carman's cannula, you can do a DMC and take out. But what is the gold standard? What is the gold standard or the confirmatory test? The gold standard investigation is all these things are blind, right? I'm not understanding what actually happens inside the uterus. I'm just inserting this instrument and taking a biopsy. It's a blind biopsy. So the gold standard is basically where I can see and take a biopsy. This hysteroscopy and endometrial biopsy. Hysteroscopy and endometrial biopsy is the gold standard, and we usually do something known as fractional curettage, where we take curette from all the walls of the uterus in fractions. Someone has written colposcopy and biopsy. Colposcopy basically means you're having a look at the cervix. So that's slightly different concept. Here it is hysteroscopy. Okay. So we have different scopies, laparoscopy, where you have a look inside the abdomen, colposcopy, where you have a look at the cervix, even the vagina can be seen in that. So, and you have the hysteroscopy, where you look inside the uterus. Okay. Yes. Okay. Yes. Okay, in vulval intraepithelial neoplasia, what is the most common cause of this condition? It's a direct question. The most common organism is HPV. Among HPV, most common is HPV 16, followed by 18. Most common is HPV 16 infection. Okay, so again, CA cervix, you take the vulval cancer, even the CIN, all these things, the most commonly implicated causative organism is your HPV infection. That is why the vaccine is very important. You have bivalent vaccine, quadrivalent vaccine, and even the nonavalent vaccine. So your bivalent vaccine is known as Cervarix. Initially you have Cervarix, you have quadrivalent vaccine, which is your Gardasil, nonavalent, which is Gardasil 9. What is the preferred target age group where you will give the vaccine? It is 9 to 14 years. How is the vaccine prepared? The vaccine is prepared from the L1 capsid antigen. It is prepared from the L1 capsid antigen. What is the dose of the vaccine? If you are giving between 9 to 14 years, you have to give 2 doses. Again, as intramuscular injection. If you are giving beyond 14 years, you require to give 3 doses as intramuscular injection. Cervarix, bivalent, Gardasil, quadrivalent, Gardasil 9, you have the nonavalent vaccine. Gardnerella vaginalis, which is implicated with your bacteria vaginosis. HPV6 and 11 are implicated with genital warts, which is also known as condyloma acuminata. 6 and 11, it is associated with genital warts. Which vaccine will protect against genital warts as well? It is your Gardasil. So Gardasil, which is the quadrivalent vaccine, it is against HPV 6, 11, 16, and 18. And you have the Cervarix, which is your bivalent vaccine, which is only against the high-risk strains. That is 16 and 18. They are the high-risk strains, 16 and 18, Cervarix bivalent. What is the significance of FSH levels in menopause? Once you see a menopausal woman and if you check the FSH levels, you see that the FSH levels are increased. The levels of FSH are usually more than 40. The levels of FSH are more than 40 in case of postmenopausal females. What about the levels of estrogen? You see that the estrogen decreases. FSH increases in postmenopausal females. You see that the levels of estrogen is less than 20. The levels of estrogen is less than 20 picogram per ml. The level of FSH is more than 40. So does that mean for every postmenopausal woman, I will check FSH? So as to make the diagnosis of menopause, should I do FSH? No. Menopause is a clinical diagnosis. If you see that a woman does not have menses for a period of 12 months, there is cessation of menstruation for a period of 12 months, you will diagnose her as menopause. So when will I check for FSH levels? In which condition? There is something known as POF, premature ovarian failure. Suppose a patient had menopause less than 40 years. If a patient has menopause less than 40 years, in that situation, you will do FSH. And if that FSH is more than 40, and you have to again repeat it after 4 weeks. So more than 40, two values are there, 4 weeks apart. 4 weeks apart, you have two values, which is more than 40. I will diagnose it as POF, premature ovarian failure. In which patients? Less than 40 years. Yes, coming to the final question. A semen analysis is shown here, and what is the most likely diagnosis? So what do you see? Various semen parameters, sperm concentration 17, pH 7.5, volume 2.5, morphology is also given. So why did I provide this question here is that so that you are aware of the latest WHO semen analysis. Okay, so till now what we have been following is the 2012 semen analysis whose parameters I have provided over here. pH 7.2, volume 1.5, total count 39 million, concentration 15 million per ml, motility 40%, progressive 32, morphology 4, vitality 58%. This is the older one. What is the newer one? Again, there is very minute changes. Okay, anyone who sees this semen parameters, the changes that has happened, it's very likely they'll get angry because the changes are so minute. Still, you have to by heart all those things, right? So you have to know the newer one as well. The pH is still 7.2. So no change. The volume, they have made it as 1.4 ml. So previously, if someone had 1.4, that was abnormal, even till 1.4 is normal. The total count 39, it is same only. The concentration, they have slightly increased. It is 16 million. 16 million per ml. Motility from 40, it has gone to 42%. Progressive motility from 32, they have brought it down to 30%. Morphology, again, same 4%. Vitality is 54%. Okay, so that you are aware of the latest one. That's why I put this question. So these are the latest one. So as in this question, as you see, everything which I have provided is in the normal range only. This is basically a case of nomospermia. Okay, nomospermia. So in case if you have already by hearted the older one, just learn the changes. Small increase, small decrease. What has happened? 1.1. 1.5, 1 point has decreased. It is 1.4. 15, here it has decreased, slightly increased, 16 million. This 40 and 32, 40 has increased, become 42%. 30 has decreased, 30%. Okay, 1 increase, 1 decrease, 2 increase, 2 decrease. Okay, you can remember something like that. Rest everything is same. Okay, is it clear? Okay. Okay, dear friends. So all the very best for your exam. So this is the time where you should work really, really hard. I know due to postponement and everything, there has been some lag that happened, right? So you might, I hope now you're properly in track. This time is extremely important. Okay. So after all this preparation, once you look back, you should never feel that if I had done this, if I had done that. Of course, some point that would be feeling, but give it your maximum. Okay, this time is very, very precious. Study well. Don't lose track. Give your 100%. Okay. Once you look back at this time, you should think very proudly, yes, I did it. Okay. This hard work is difficult. This working, this late night studies. I know everything is difficult. Remembering this, there is stress. All these things are there. But once you become successful, once you get that desired seat, it is going to be all worth it. Okay, so study very well. Don't waste any time. Give it your maximum. Okay, give grand tests, do questions, revise fast, revise rapidly. Okay, go through your notes. This time should be for revision. Do not spend a lot of time like going into new topics, discovering something new and going behind that. Okay, keep on revising, revising. Revision is the key at this point of time. Okay, all the very best for your exam. Okay, study well and hope to hear from you after the exam as well. You can connect to me even after exam. This is my Insta ID. Even in between as well, if you have any doubts, questions, you can connect to me anytime as well. Okay, so all the very best, students. Okay, thank you, Devi, Gajendra, Ishan, Kalimikonda, 𝗵𝗗cie, 𝗵𝗗cie. Yes. Okay, all the best. So, is there any questions or doubt? Okay, so if at all you have any questions, doubt, you can message me as well. Thank you, Mukesh. So PDF, I think it will be soon available in the group. I'll just check with the team as well. Thank you so much. Okay, so all the best for your exams. Okay, make the most of this time which is left.